Hello everyone. Today, after having discussed most of the concepts in conventional ventilation, we would have an introduction to another mode of ventilation, the high frequency oscillatory ventilations. Well, one thing is for sure, if you are going to put in a tube, you are going to create lung injury. So ventilation is definitely to induce lung injury. So now the question asked is because you cannot prevent intubating and ventilating babies. So what is the safe window or where is the safe window for preventing lung injury when you ventilate babies? Well, we have seen this. If you overinflate, you are going to create volutrauma, barotrauma. If you do not recruit the lung well, your PEEP or CPAP is not adequate, you're going to create atelectotrauma. So there is a safe window in between where lung is well opened. The concept is called open lung concept. So where lung is well opened and then you use minimal pressures to ventilate. So this is the safe window theoretically for ventilating babies. Well, now let's see the practical difficulty of this. We have learned that minute ventilation, which is the gold standard in clinical practice for measuring the how much ventilation that you're doing, is a product of tidal volume and ventilation rate. So tidal volume is proportionate to the delta P. So the more window, the higher the PEEP or lower the PEEP, you get more tidal volumes. In which case, so if you want to reduce lung injury, you need to reduce tidal volume. So probably the only way to get minute ventilation right while reducing tidal volume is to increase the ventilatory rate. Can we possibly achieve this and prevent VLE by reducing TV and increasing the rate in conventional ventilation? Probably no, because studies have shown that if you keep on increasing the ventilator rate more than 60, 70, 75, probably the ventilation that takes place comes down drastically. So we cannot achieve ventilation and try to prevent VLE by reducing tidal volume and increasing the rate in conventional ventilation. That's where the role of HFO ventilation comes in. What is high frequency ventilation? It is nothing but an old wine in new bottle. We all know this famous observation by Henderson long back, 1915, that dogs pant, and when they pant, they use tidal volumes less than the dead space, but they ventilate the lungs well. So very minute tidal volumes at a very high frequency probably is also effective. How does this principle work? Well, there are various theories, and the very fact that there are 8 theories to explain means that probably we really don't know how it works. But then the explanations given, one is the bidirectional ripple effect. You throw a stone in the water, you find ripples traveling in both the directions. So you have a two-way traffic in high frequency ventilation with an asymmetric velocity profile. So usually you have inhalation and exhalation taking place at the same time. Well, this is where HFO scores, and conventional ventilation probably has the problem here. Conventional ventilation is a one-way traffic where in the active phase, you actually ventilate, you inhale, and then exhalation is a passive process. So in conventional ventilation, you have only one-way traffic, whereas in HFO, we said the bias flow that is produced creates a dynamic seal, and then the mean airway pressure is used, and there exhalation and inhalation takes place at the same time. And does it really help? Now we know from animal studies, it really opens up the lung and ventilates very well. So lung can be better recruited with a higher mean airway pressure and then very small rates if you use on top of that. Based on this principle, we have various machines available now in HFO. The sensor medics, what is shown in the middle, is probably the king of all the medicine, all the ventilators in high frequency. And then we have the newer ventilators, the various brands that are come into the market, which all basically provide high frequency oscillations. The basic components of a HFO ventilator: you have a bias flow system that generates the mean airway pressure by the gas flow, and then the gas is driven by the driving system by the oscillating piston, which actually creates a movement of gas in and out by and creates small changes in volume. That is a VTHF or tidal volume in high frequency. And then this is, you need a interface. So the transmission link is also a part of this. How do you control? We learned in the conventional ventilation, we have various buttons: PIP, PEEP, rate, FiO2, IE ratio, various buttons. Here, the controls are very limited. You have just 4 controls. The advantage, the theoretical advantage, I would again say theoretical, because later on you will realize it is not always true. But then theoretically, oxygenation and ventilation are decoupled in HFO. So if you want to control oxygenation, suppose just take the other example, conventional ventilation. If you want to increase oxygenation, you need to increase the PIP. But if you increase the PIP, carbon dioxide elimination also increases. So both will increase if you touch the PIP button. Here you have different controls. So oxygenation, there are 2 buttons that control oxygenation: the mean airway pressure, the parameter that actually determines the recruitment of lung and oxygenation. And of course, you have FiO2, the amount of oxygen that is present in the gas that you give. For ventilation, you have just 2 buttons. One is your amplitude or delta P, or the power button, which you use, and when you increase it, more CO2 is washed out. Frequency is another button that is similar to, it can be synonymous with the ventilator rate button in a conventional ventilation, but there are some differences in this frequency. These are very high rates, and we will come to the differences subsequently. Let's first discuss a bit about oxygenation. Oxygenation, I said, is determined by MAP and FiO2. So mean airway, FiO2, of course, is very simple. You increase oxygenation, improve, and then you reduce, probably the oxygen percentage in the air is less. Mean airway pressure is the button that you play around. And now, when you initially, to recruit the lung, you increase the mean airway pressure, and this is what happens. And when you increase the mean airway pressure, the lung opens up, and you can, more alveoli are opened up for gas exchange. And once you have that, this is like a balloon. You blow a balloon. Initially, it's difficult to blow, and then after a period, it becomes very easy. That is the time. That is because you have recruited the lung. And at this point, very small changes are enough to effectively exchange carbon dioxide. All right. So far, so good. But then it's not all that rosy. We all know that when you use HFO, in the early days, the problem people used to have was that the MAP used to be set higher, because just imagine mean airway pressure of a baby in conventional ventilation. Suppose it is 12, you think it is very high, and you're looking for some other mode to actually reduce the damage. Whereas in high frequency ventilation, 12 is sometimes the value that you start with. So higher mean airway pressures can be safely used in high frequency as compared to conventional. But the problem is that where is the fine line? How long will you increase the mean airway pressure? And finally, it will happen that the higher mean airway pressure will actually create cardiac compromise, and then air leaks. pneumothorax, etc. When the lungs are over-recruited, heart becomes under stress, and so you can detect this. So the higher MAP, you can detect while ventilating a baby. If it is excess, you will find that the urine output of the baby comes down. The lactate will increase, that heart rate will increase. So these are all telling you your mean airway pressure may be higher than what is actually required. So how do we oxygenate properly? When in the current era, how do we use the MAP button? You use this mantra: recruit, de-recruit, and re-recruit, which means that you use a higher pressure to recruit the alveoli, and so the mean airway pressure that you use to recruit alveoli may be as high as 18 or 20, and as soon as you achieve your recruitment, you wean. It is not in hours or days, it is in minutes. So after you achieve your recruitment, you start. So if you are, suppose you have reached up to 20, you require a mean airway pressure of 20 to recruit, then you bring down by 19. You will find that if your lung is well recruited, still the baby will be saturating well. You bring it down to 18, still the saturation will be good. Bring it down to 17, still you will find it's good. Bring it down to 16, you will still find oxygenation is good. Bring it down to 15, suddenly the lung has become de-recruited and saturation falls. So the pressure that you would set initially to continue in the high frequency will be 1 or 2 above the de-recruiting pressure, with which you are able to. So from 15 you go to 16, suddenly saturation will improve now because lung was already recruited. The lung that you de-recruited was already a recruited lung, so it requires lower pressure. So 16 or 17 will be enough for you to recruit. So the setting that you use initially will be 16 or 17, not 20. If you had not done this maneuver, you would have started with 20 and then you would have landed with pneumothorax and cardiac compression. So this is the mantra for using lowest mean airway pressure and effectively oxygenate the lung. Let's come to ventilation now. Ventilation is basically measured by the carbon dioxide clearance. We all know that. And there are two buttons I said, the amplitude and the frequency button. So increase the amplitude, more CO2 gets washed out. And whenever you increase the amplitude, you make sure that you check the mean airway pressure after that, so that the amplitude does not affect the mean airway pressure, even though we said they are decoupled. Frequency is a more powerful tool, and here the equation is opposite. You use lower frequency, more CO2 gets washed out, lower CO2 will happen. So this is the opposite effect. In conventional ventilation, you increase the rate, more CO2 gets washed out. Here, you lower the frequency, more CO2 gets washed out. Why does this happen? Well, this is because the amount of CO2 washed out is something like can be represented like a stroke volume when you of the whole process. So when you increase the delta P, the volume, the area increases. But when you increase the frequency, what happens? You have to get into the next. So the total area is going to come down. Whereas if you reduce the frequency, longer cycle time will enable more area. That is why smaller frequencies, because these are very, very small frequencies, lesser than the dead space ventilation that's what you're doing. So here, smaller frequencies will be more effective. I'll explain this further subsequently. So before that, just remember amplitude or delta P, what you set on the ventilator will not be the one that is delivered at the to the alveoli, because there is attenuation. So whatever you set will reduce. So it is, how do you make sure? Because unless you deliver enough amplitude, HFO will not work. So once you have set the baby on HFO, the first question that you're going to ask is my HFO working? And how do you know that? By seeing wiggles, chest wiggles, so and abdomen wiggles. So how do you make sure that you see this? Actually, you need to kneel down and look at the baby horizontally. And when you look at the baby horizontally, you will find that the wiggles are happening. Idea is to have gentle ventilation, which means that you need to use the minimum oscillations to get vibrations up to the lower part of the abdomen or upper part of thigh, not more than that. If you use more, so if you increase the delta P, you will find more oscillation. That will be excess of CO2 washout. And we already have discussed that excess CO2 washout is not a good thing. We need to make sure that we only give what is required, not maximum. Less is more in neonatology, as I keep telling. All right. That's about amplitude. Now we come to frequency. Frequency or amplitude, as I said, lower frequency, more ventilation. But another principle is also there. Maximum air exchange or maximum movement is or ventilation is at the resonant frequency. The typical example is, if at all any of you is exposed to armed forces, when soldiers walk on the bridge, they are asked to break steps. If they walk in the same steps, the frequency that is generated by some misfortune actually equals the resonating frequency of the bridge. Bridge will start moving and then bridge breaks. There are historical examples, some of you may be aware of. So gas moves, so the ventilation happens maximum at a particular resonating frequency. Each matter in physics has a particular frequency. Lungs also have a natural or resonant frequency. And this frequency is where maximum air movement takes place. Theoretically, this frequency can be like 4 to 8 hertz in adults, 10 hertz. 1 hertz is 60 oscillations. Okay, mind you, I hope all of you know that. 10 hertz in a term baby and higher in a preterm baby. 12, 15, periviable babies, even 18 hertz is the frequency at which lung maximum ventilation happens. But these are values that help you to start. So a term baby, when you set a baby on HFO, you may start to 10, and a preterm baby, you may start to 12. Previously, when we were trained, we used to be told that once you set a frequency, don't touch it. The concept is more refined now. We adjust frequency, but the adjustment that you make in frequency, like if you increase the frequency, less ventilation happens. If you reduce frequency, more CO2 gets washed out, and then so you have to be very careful. This is not a fine adjustment like the adjustment that you do with delta P. So these are the two buttons, delta P and frequency. There is another button which you have in conventional ventilation, that is a IE ratio. So IE ratio is there in the original HFO machine, Sensormedics also. I means the time, how is HFO generated? By the forward and backward movement of the piston. So the forward movement time is I time, and E time is the time, the backward movement of the piston, not of the baby. So IE ratio 1:2 is what you use in very powerful HFO machines like Sensormedics. Whereas in less powerful and more refined machines like SLE, VN500, VN600, etc., you use 1:1 as the IE ratio. Some of the machines have inbuilt ratio, so you don't need to worry about it. So I have presented a mode of ventilation that is highly sophisticated but very superior in theory. We said we are ventilating in the safe zone, so no chance of any other ventilation-induced lung injury. So in theory, it is superior, but in practice, those who used to when we used to ventilate babies in the last century, we used to see that these babies used to have pneumothorax, and the CO2 used to be flushed out like anything. You know, the moment you convert the baby on HFO, CO2 just drops. This is bad for the baby because you drop the CO2, you play with the hemodynamics in the brain, and you are going to create brain injury. So hypocarbia, hypercarbia, sudden changes are very, very bad. You don't want that. And the mean airway pressure, when you increase it too much, you tend to increase unless you follow the maneuver, you will cause pneumothorax and then end organ manifestations of poor cardiac output. As I said, tachycardia, hypotension, poor urine output, rising lactate, etc., etc. So in practice, people in the previous era used to see that HFO was not superior. And so then when you have that contradiction between theory and practice, let's look at the evidence. Is there any clinical evidence of benefit of HFO over conventional ventilation? Well, this is a study at the beginning of this century, a meta-analysis, and then we have seen that the diamond is just in the middle, which means that it neither favors HFO nor conventional ventilation. So there is no superiority as far as evidence is concerned. Actually, in the previous century, there used to be worse output also with HFO, like the hypercapnia because of the sudden fluctuations in the carbon dioxide, which resulted in higher babies landing with brain injury, IVH and all, in the HIFI study, HIFO study, French multi-center study, etc. So the conclusion those days was HFO is inferior. Don't use HFO in preterm babies. What is the catch? Where is the catch? Well, now we know that it might not be so. We became experts in conventional mechanical ventilation. This is not IMV. This is CMV here stands for conventional. So we were experts in conventional ventilation, that we have targeted volumes, and then we know how to be gentle on ventilation. Whereas HFO, we just start when CMV fails, we go for HFO. And then you do it very badly. And then evidence, what are you doing? You're comparing apples and oranges. CMV that is done well is compared with the HFO that is done very badly, crudely. And different cases, selection is bad when the HFO is used as a rescue therapy, not as an elective therapy. If you compare like that, definitely HFO will be inferior. And do not blame it on HFO, because there is a theoretical superiority. This is what led to the thinking that there may be something wrong. At the beginning of this century, there were two studies, landmark studies, one from US by Courtney et al. And one from UK by Johnson et al., which looked at similar parameters in preterm babies. HFO, they compared with SIMV, which used to be the mode those days. We don't, the SIMV is almost becoming outdated now. We use assist control as we discussed the other day. But then, of course, SIMV also has a place. I'm not denying it. So HFO versus SIMV were the thing. And then they found that UK, even though UK is more organized, the study selection was not as sound as the Courtney et al. Americans might be very casual, but then the study was very systematic. And then they found that there is significant outcome differences, superiority of HFO as well as BPD is concerned. Subsequently, the interest came. Okay, so preterm babies, that is the outcome that people are all worried about. Other outcomes nullified. So if you want to prevent BPD with ventilation, then can we use HFO? Probably the UK study also, the long-term arm of this, the UCOS long-term respiratory study also probably points to the superiority of HFOV. So HFOV now is thought as a lung protective mode in good hands for preterm babies. Here, before I proceed further, let me make a very, very important statement. You save maximum babies and your outcome is best in the mode that you are most familiar with. If you are not familiar with HFO, do not use it, you will kill babies. It is only when you are familiar with everything, your expertise is as good as your expertise in conventional ventilation using targeting tidal volumes, then only HFO may be more lung protective than conventional ventilation, as has been shown in some of the recent studies. Why? Why is HFO more lung protective in preemies? Well, technology is the main important factor. Machines have better algorithms now. So the fine-tuning of ventilation is possible. And then we now are experts in recruitment, de-recruitment, re-recruitment maneuvers to prevent cardiac compromise whenever we use it, even for as a rescue modality. So pneumothorax, cardiac compromise, etc. are less. And most importantly, it is because of this man, Professor Samuel Sanchez Luna from Spain. Now it is feasible to target tidal volumes in high frequency oscillation. This is a concept that has come up in the last 2 decades, and the newer ventilators, mind you, Sensormedics, the king doesn't have this. So the newer ventilators, you have an option to target tidal volumes in HFO also. Why should you look at targeting tidal volume as a superior mode? Well, we have seen in the previous lectures that volume targeting improves neonatal outcome in conventional ventilation. Studies are profound. All the short-term outcomes are better in volume targeting. That CLD, IVH, pneumothorax, number of days of ventilation, the cost, everything is less if you target tidal volumes in conventional ventilation. You have the recent Cochrane database that has looked at it very extensively. What about in HFO? Is it feasible to target tidal volume, and will it improve outcome if you target? These are the 2 questions now we will, in the last part of this lecture, we will cover. Is it possible to target tidal volumes? Well, this we thought is a difficult question because the mechanism of ventilation different. The gold standard, I said, in conventional ventilation is minute ventilation. Minute ventilation is dead space ventilation plus alveolar ventilation. Whereas in high frequency, you are ventilating only dead space. So how do you actually protect when alveoli are not being ventilated? So here the concept is that high frequency oscillation, the targeting is related to the high frequency expired TV, VTHF. When the piston moves in and out, a small volume is generated. This volume is being targeted for differential CO2 washout. Okay, so we all know this. Now air comes, so ventilator is a T-piece, air comes, so imagine this portion is not there, air comes, and then when the valve is closed, it goes into the lung. When valve opens, it goes out. So that is PEEP. When valve closes, PIP is generated. Now what we are doing is we are creating a bias flow by putting an oscillator, and that is how HFO delivers tidal volume. And this is how you eliminate CO2. Now this volume VTHF will increase if you, we said already, if you increase the amplitude, if you decrease the frequency, and if you increase the inspirated time. But these are things that you have control on. But there are other things on which you do not have control. It is tube size. You need the largest size and its characteristic, how pliable it is, the compliance of the tubing, the performance of the ventilator, what is the power of the ventilator, what is the lung condition. So what is actually happening, even if you have perfect control on the amount of VTHF that you want to deliver, it will vary because of all these, and the disease condition will accentuate this variation. So unexpected variation of CO2 removal will happen. That is why we had very poor outcome in the previous era. So we have a new concept, which is something like your alveolar ventilation in conventional ventilation, that is a DCO2. So DCO2, we said minute ventilation is a product of tidal volume and frequency, whereas DCO2 is a product of VTF square and frequency square. So then it makes sense. Lower DCO2 means you have less ventilation happening and high PaCO2. Higher DCO2 means more ventilation happening and lower PaCO2. So if you use HFO, the problem is DCO2 fluctuates because of baby movements, position of the baby, spontaneous breathing, some secretions are there. So before suction, after suction, all the CO2 values will keep fluctuating. And when the caregivers handle the baby, again the values fluctuate. However, and this is probably the result resulting in all the brain injury that we previously discussed. Why in practice people found in the previous era, HIFI study, HIFO study, French multi-century HFO trial and all that it actually creates brain injury. But now, thanks to this man, targeting tidal volumes is feasible in HFOV. And it has now resulted in a stable DCO2. This is when you do not target. You have a delta P that you are set and the DCO2 varies. Whereas here what happens, you don't set the delta P or amplitude when you target tidal volume. You just set the tidal volume. And so to deliver the tidal volume, whatever is the delta P required, the machine gives. And you have a stable DCO2. This is how tidal volume is targeted in high frequency ventilation. Okay, so I said you should set a tidal volume instead of delta P. What is the tidal volume that you should set? What is the optimal tidal volume? Again, go back to the old principle. HFO in dog, we said Henderson observed, it is a dead space, where less than dead space is the area that is being ventilated. So only dead space should be ventilated. And what is the dead space in a healthy awake neonate? It is something like 1.5 to 2.5 ml term baby. This is just a value for you to remember. So remember, when you set a tidal volume in HFO, never exceed 2.5 ml per kg. You will hyperventilate. Usually, I am passionate about this mode. I use this mode very frequently whenever I have a machine in which I can use this. So I usually start with 1.8 to 2 ml per kg as the starting tidal volume and then wean as the baby's gas improves. Okay, that so far so good, but will it actually improve the outcome? This is $1 million question where technology is outpacing the evidence. Technology has made this possible. Now we need to collect evidence for this. There are only very few studies which have looked at this, and all these studies have shown that lesser fluctuation of DCO2 when volume is targeted. And even Martin Kessler's small observation study, they found even oxygenation also is stabilized, heart rate is stabilized on volume guarantee, that they use VN 500 for this actually. So evidence, all the evidence we have are positive, saying that targeting tidal volume improves outcome, but the evidence is not strong enough to recommend it as a standard of care. What is the future for this? Well, future is always no tube ventilation or gentle ventilation. If you put in a tube, gentle ventilation. Gentle ventilation, we said lowest tidal volume possible in a recruited lung in conventional ventilation. Here, higher frequencies are lung protective, lower MAP is lung protective. So use the lowest MAP possible and use highest frequency and lowest VTHF. All right. So this is anyway the future. There are only animal studies, again by the same group, by Professor Luna group. They have shown this to work. And those of you who have heard some of the lectures I happen to host, the Learn from the Legend series, where Professor Luna has elaborated this in 2 of his lectures rather. So why this concept works? Only this concept of higher frequency and lower tidal volume. That's a very difficult proposition. How does why does it work only in volume guarantee? Probably because you need a leak compensation algorithm. So only the sophisticated technology can enforce this. So how do we prevent VLE in preemies using HFO? Use lowest MAP and highest frequency possible. That's it. Now let's sum up. HFO, to advantages, it improves gas exchange and lower pressure and volume swings, more uniform lung inflation, great for homogeneous lung disease, reduces air leak. All these are advantages if you use it properly. But if you do not use it properly, if you don't know how to use it properly, it has a great potential for gas trapping, overinflation, rapid CO2 clearance, and lot of brain injury. And of course, it may not be as effective as a homogeneous lung disease. In patchy lung disease, it may not be as, you can use it, but it's not as effective. Whenever you use HFO, make sure you document all the parameters, and this chart has to be done on a 15-minute interval, or even especially if you do not have a log record that can be taken out from that, so that you can know all the parameters. If you're not using volume targeting, record the VTHF delivered and the DCO2, etc. If you're using the targeting, if you're targeting tidal volumes in HFO, then record the delta P required to attain that particular tidal volume as well. Okay, now some very basic concepts. I hope all of you know this. Use appropriate ET tube and size, the largest size, because minimum leak is where HFO is maximum effective. And always you need a clean airway. So suction, consider a closed suction, because if you use an open suction, every time you suck, you de-recruit the lung. So that is a counterproductive exercise. So use a closed suction if possible. And I would say consider sedation, no paralysis in selected cases. But in preterm babies, no. This is if you're using it for meconium aspiration syndrome, PPHN and all that. And then, of course, monitor the various parameters. Previously, we used to take X-ray every 6 hours and all that. Then it became a once a day. Now it's as and when required. So blood gas also we used to do 6 hourly in the previous. Now, as you have more and more sophisticated parameters like your DCO2, the tidal VTHF, and the graphics available, probably even blood gas also can be cut down from 4 times a day to 3 times or 2 times, or even once a day, depending on how comfortable you are. Always HFO can be used when you get stuck with conventional ventilation and it may work. That is your rescue mode. Sometimes as an elective mode you can use, and that is what probably will give the best advantage for HFO. But for that you need a lot of expertise, lot of excellent nursing care, or you can follow a via media semi-elective. When baby is likely to deteriorate further itself, you convert. This is what I do most of the time. Look at the current mean airway pressure when you convert. Look at the disease pathology, and then actually recruit the lung well. Look at the size of various. These are various parameters that will affect your choice of settings. I'll stop here. Again, I'm repeating what I said in the previous lecture. Our idea is not to cause harm. So first, do no harm, which means that ventilation, if you do not ventilate, baby. And if you ventilate, be gentle and as extubate as early as possible by proven methodology like targeting tidal volume in conventional ventilation, and then HFO by fine-tuning your skill of HFO. Lowest MAP and highest frequency are most protective in high frequency ventilation. I think I will stop here now. We can have